Hello, I'm Bernard Dan. I'm the Editor-in-Chief of Developmental Medicine and Child Neurology. Today we're recording a podcast together with Dr. Valkenburg from Erasmus University Medical Center in Rotterdam in the Netherlands on his paper, Pain Sensitivity of Children with Down Syndrome and Their Siblings, Quantitative Sensory Testing versus Parental Reports. And this paper appeared in the November 2015 issue of the journal. The authors were Bram Valkenburg, Dick Thibault, and Monique van Dijk. Hello, Dr. Valkenburg.
Good afternoon.
You work in Erasmus University Medical Center, and where more precisely?
The research was conducted as part of my PhD at the Department of Intensive Care and Paediatric Surgery, but currently I'm an anesthesiology registrar at the same University Medical Center.
Right, so your interest was an interest in pain evaluation, more specifically in children, and then you started wondering more specifically in Down syndrome, is that correct?
Yes, that is correct.
In Down syndrome, there's been this notion of hyposensitivity. What can we say about this notion? What does it mean, hyposensitivity?
Children with Down syndrome were often believed that they are less sensitive to pain, and because these children often have congenital anomalies where they need surgical procedures for, it was believed that they are less sensitive to the pain from the surgery and need less analgesics after a surgical procedure. And that's a little bit where it started.
Has that been your experience in intensive situations or in pain treatment situation?
It is part of old textbooks on intensive care that it is right about children with Down syndrome, that they are less sensitive and that they need less analgesia. But it could be a little bit a myth more than reality.
Mm-hmm. Now, when we talk about hyposensitivity, does it refer to the sensation or to the perception of pain, or to the reaction and to the behavioral and motor efferent actions following the interpretation of a painful stimulus?
The hypo-sensation or hypersensitivity would refer mainly to the reaction to pain, because that is what is noted by caregivers, for example parents. They note the reaction of a child to a painful stimulus, and the perception of the stimulus, that's what the child itself feels, that is more difficult to assess. So this concept of hypersensitivity is mainly formed by caregivers as parents or nurses or doctors that see the reaction of a child to a painful stimulus.
Right. So in that context, how did you design your study?
We designed our study to look at children with Down syndrome compared to their siblings, and we wanted to have a sample outside of the hospital. So together with the Parental Organization for Children with Down syndrome in the Netherlands, we asked permission to visit the children at home and do the study at home, to take it away from the hospital, and to do an exploratory study on their pain sensitivity and pain reactions as a general sample. So not a sample that already was in hospital for surgery, but a general sample of children with Down syndrome.
Right. And what did you find?
We compared the reactions of 42 children with Down syndrome to 24 siblings, and we observed that the children with Down syndrome were less sensitive to cold and warmth when we measured it with a reaction time dependent method. But when we take a reaction time independent method to assess their pain sensitivity, we don't observe the differences anymore.
And the reaction time, that was assessed visually. That is a measure of the behavioral response to pain.
Indeed, and it's a visual motor reaction time that we assessed independently of the pain sensitivity tests.
How painful were the stimuli? What did the siblings say, for example, and what did the children with Down syndrome say?
Tests we use to assess their pain sensitivity, the broader term is quantitative sensory testing. And we use the stimulus warmth and cold because it's a good measure for the pain sensitivity. And the device works that it starts at the temperature of the skin. The first question is, when do you feel that the temperature of the probe changes? That's the first test. And the second test is, when is this stimulus starting to get painful. And the device is designed that it can't damage the skin. So it's just the temperature where the children feel it starts to get painful.
Mm-hmm. And how did the results compare between the siblings and the individual with Down syndrome?
First of all, it's important to mention that not all children with Down syndrome were capable of performing the tests with this device, because it's asked for some comprehension of the test, and we had the idea that it was not feasible in all children with Down syndrome. Mm-hmm. But if then the tests were feasible in the children with Down syndrome, we observed that the children with Down syndrome were more sensitive for heat pain than their siblings.
And that is from your observation of the behavior and also questionnaires?
Yes. Next to these tests with the quantitative sensory testing, we also had some validated questionnaires for the parents of the children, looking into chronic pain, but also to pain coping, and looking into pain behavior. And if we first look at their pain behavior, we found that parents rated their children as less sensitive to pain, and asking for examples. Most parents had good examples illustrating why they thought their child was less sensitive to pain in clinical settings, for example.
Oh, right. So for example, a needle prick, and they thought
Indeed.
that the child reacted less than they would have expected.
Indeed.
Mm-hmm. And so was there a difference in these responses to the questionnaires between the parents and the children?
The questionnaires were mainly for parents of the children with Down syndrome.
Right.
And because those questionnaires are all validated as parental questionnaires. And if we then compare the answers of the parents to what we observed during the tests, there was a discrepancy between the two, because parents rated their children as less sensitive to pain. But looking at the results from the quantitative sensory tests, we had the feeling that children were more sensitive to the pain for
right.
stimulus.
So obviously the comparison is difficult there, because the measures are not the same, but you're suggesting that we should revisit this notion that the children are simply less sensitive. Is that correct?
That is correct, because of course parents see their child every day, and they have good examples why they think the pain behavior of their child is different. But the pain behavior might be different, but that does not implicate that there is a difference in their pain sensitivity. So both parents and clinicians should be aware that their child might be responding different, but that the level of pain sensitivity might be comparable to children without Down syndrome.
Right. You studied it very thoroughly in standardized conditions, and you comment that a proportion of the children with Down syndrome just didn't fit. It was just not practical for them, this artificial setting. And interpretation of stimulation depends on many factors, and there's a lot of complexity. And perhaps the first factor for complexity is the difference between heat or cold sensation and heat-related nociception, isn't it?
That's right, because normally warmth is a pleasant feeling. Going in bath or the warmth of the heating in winter, it's a pleasant feeling, and it's not always associated with an unpleasant event like unexpected heat. So that's of course different, but it's the most ethical and best validated method to assess the reaction to painful stimuli that there is available for children.
Knowing also that there is a long way from the primary stimulus all the way to interpretation and also to behavioral reaction. Where do you think we should go to now in terms of research to get more precise answers? Because clearly you have opened a window here in a domain where there seem to be consensus around the notion that individuals with Down syndrome are less sensitive to painful stimuli, and now you provide evidence that this may not be the case. How do we move forward in terms of research?
I would like to translate it into clinical practice, because one of the reasons why we did this study is that children with Down syndrome often undergo, for example, cardiac surgery, which is a huge procedure for the children at their age. We know that it is very important to assess pain adequately and treat it accordingly in a clinical setting. So it would be ideal to translate the findings into clinical practice and develop the best methods to assess the pain of children with Down syndrome in the hospital and make sure that we customize their pain treatment to the reactions.
To pay specific attention to pain, make sure that we have the right tools, and we might have to create some. In the meantime, are you finding that some tools for assessing pain are better indicated in individuals with Down syndrome?
One of the issues with assessing pain in children with Down syndrome is that, especially in older children, that self-report will not be reliable in children with Down syndrome. So we need to use more observational pain instruments for this group. And there are a few good validated tools available. And my suggestion would be that more clinicians are familiar with these tools and use them. And the second thing is that treatment of pain is not only pharmacological treatment, but also non-pharmacological. And it would be a good suggestion to develop distraction methods to make it easier for children with Down syndrome to cope with situations in the hospital, for example, pain. And we observe that because the pain coping of children with Down syndrome is they have less strategies than their siblings. It could be an important aspect for parents and caregivers to look into good distraction strategies for children going into hospitals.
Okay, and I think that what you've just mentioned, the role of parents and the role of siblings is also very, very important and will be important in research also, because what you did in your study was to try and create a convergence between parental perception and your measurements, but I'm sure we still need to learn a lot from the people who know those children best, and these are the siblings and the parents, don't you think?
That is very important, and we would like to know why is the reaction of children with Down syndrome different from what we expect? Is it their developmental disability, or are there aspects associated with the trisomy 21 that makes the pain reaction different from what we expect?
This is a very important domain of research. I think you were very thorough in your ethical approach, and that needs to remain central to any study into this domain. Well, thank you very much, Dr. Valkenburg, for sharing this with us.
Thank you, Professor Dan.
And, we would like to see more of your work, so we will let you to it. Thank you. Bye-bye now.